Señoras y señores, ladies and gentlemen, thank you for joining us at this up-to-date session this evening. The session will be co-chaired by Dr. Lilian Costallat here at the table with me, who is a rheumatologista da Universidade Estadual de Campinas in Brazil, and myself, Alejandro Alvarellos de Córdoba, Argentina. It's a pleasure to welcome our speaker, Dr. Liz Lightstone from UK on her first visit to Argentina. Dr. Lightstone is an academic nephrologist from Hammersmith Hospital, and her major interests are renal transplantation and lupus nephritis. Her conference will be a most challenging one. Lupus biopsy, the nephrologist point of view. Liz.
Thank you very much. It's an absolute pleasure to be here, and I could give you a very short talk and time to be tourists it's always a bit dangerous being the nephrologist in the lion den of rheumatologists. And when I gave a talk to the British Society of Rheumatology a year or so ago about what the rheumatologist needs to know about lupus nephritis, I started with one slide, which was send them to a nephrologist. And you might say the same about a renal biopsy, but I won't be that contentious, and I'm very flattered you've come this afternoon to hear this. So my disclosures. So treating lupus nephritis, we aim to induce and maintain a remission and preserve renal function. We want to prevent renal disease flares. We want to avoid treatment-related harms. We want to improve the quality of life and survival. And to do that, we need to know how severe the disease is. So we have to have a renal biopsy, certainly at the outset. We clearly also need to know what the patient's fertility wishes are, their pregnancy plans, and their previous treatment, and in fact their previous biopsies. So why is the biopsy so crucial? Well, you have to make the diagnosis, and it's not always what you expect. You need to define progression and scarring if there is, and you need to know what's going on if they appear to be flaring. And I would argue, and hope I'll persuade you by the end of this, that you can also use it to define remission. So the biopsy, in my view, clearly influences management. It tells you about severity, it tells you about chronicity. You can't do anything about chronicity, so you've always got to make a judgment about how much chronicity is there and how aggressive you're going to be about the inflammation. And biomarkers, which are not yet being used routinely, but may in time become useful when we do more clever staining with the biopsies. There are some limitations, and I'm going to address those, particularly the issue about segmental versus global lesions and predicting who's going to do badly, because you need to know that from the outset. So I always like to start with a case, and as you'll see, this is one of my very special patients. He was a young male patient who was first seen at the Hammersmith Hospital aged 18. He was born in the UK of Pakistani parents, and it's important to note that even before he got lupus, he'd had slipped femoral epiphyses in 1997, which had been fixed in situ. He initially presented as a child, aged 13, with a widespread symmetrical polyarthralgia, general malaise, and he was treated symptomatically by paediatric colleagues. But quite soon after his initial presentation, he became extremely unwell. He developed cerebral lupus and acute renal failure and was transferred to the paediatric ICU, where he was noted to have ANA, anti-double-stranded DNA, anti-SM at high titer. He was presumed to have cerebral lupus, and interestingly, he was treated only with high-dose steroids and antibiotics initially and made a remarkable total recovery. His disease was then well controlled with azathioprine, hydroxychloroquine, and he was well enough to be weaned off his steroids by the end of 2001, when he was 15. But in May 2002, age 16, he developed significant proteinuria, 8 grams in 24 hours, with a creatinine that was possibly marginally elevated for his age. Again, he was hypocomplementemic, he had high levels of double-stranded DNA, and a renal biopsy at that point showed diffuse mesangial expansion, cellular proliferation, no chronic damage, minor tubular atrophy only, full house immunoglobulins, and he was diagnosed as having a lupus nephritis class 4G entirely active. And he was treated entirely appropriately. His initial treatment was MMF with oral prednisolone, because giving young men cyclophosphamide is problematic in terms of fertility. But his proteinuria persisted and his renal function, however, was stable. He was then given cyclophosphamide, high-dose NIH cyclophosphamide and azathioprine, and interestingly has a testicular biopsy stored at the paediatric centre. But he continued to have proteinuria. He was hitting aged 18, and he was transferred to our care. When he came to see me, he was Cushingoid. He'd been on Pred 25 milligrams for months and months. His blood pressure was well controlled. His renal function was reasonably good, but he was nephrotic. He had an appalling cholesterol. His LDL was 6.5. He was lymphopenic, and he had 4+ protein, 3+ blood, and he was strongly DNA positive, hypocomplementemic, and in those days we were doing anti-C1q, and that was strongly positive. So we repeated the biopsy, and I'll come back to his biopsy when I've told you a little bit more about biopsies in general. So when we're talking about the biopsy in lupus glomerulonephritis, what we're talking about is the glomerular injury. And the glomerular injury is determined by the site of immune complex deposition. It depends on multiple factors, including antibody specificity, affinity, and avidity, as well as antibody class and immune complex size. And depending on where those antibodies sit, it's going to be easier for me to indicate with this, depending on where those antibodies sit, depends on where you get your electron-dense deposits and the injury that ensues. So if your immune deposits sit on the endothelial side of the glomerular basement membrane, they activate cells and you get an endothelial pattern of injury with proliferation consistent with lupus class 3 or class 4. If they sit on the epithelial side, on the side of the podocyte, as shown here schematically with nice foot processes, you never see those nice foot processes when they've got good going subepithelial deposits, then you get an epithelial pattern of injury in a class 5. When they simply sit in the mesangium, that's associated with a class 2. And that's seen on light microscopy here, where you have mesangial deposits. Here you've got mesangial proliferation. There's too many cells in these areas in the glomerulus. Where you get subepithelial deposits, you get these sort of thick, solid loops, which are full of subepithelial deposits in a membranous pattern. And when you get subendothelial deposits, and if my colleague Agnes Fogo from Duke was here, she'd say subendothelial deposits are bad. You can see there's no open loops here. This is what your capillary loops should look like, nice lacy loops. Here there are none because they're full of subendothelial proliferation, far too many cells, and a nasty class 3 or class 4 lesion caused by the subendothelial deposits. It is worthwhile remembering what the natural history of lupus nephritis is. We always talk about the proportion of tubulointerstitial scarring predicting outcome, but that's because we treat patients. In 1964, Pollock did a biopsy study, and he compared patients with normal biopsies, interesting ethically, lupus glomerulitis, active lupus glomerulonephritis, lupus glomerulitis being essentially mesangial proliferation, and membranous lupus nephritis. And he also scored active and inactive lesions, and he followed 87 patients from 7 months to 8 years. These were classified only on light microscopy, and they were very good prognostically. If you don't treat lupus nephritis, if they have normal biopsies, glomerulitis, mesangial proliferation only, or membranous, only 2 out of those 40 patients died in renal failure. Remember, in 1964, if you got renal failure, you died because no one was being offered dialysis. But the patients who had lupus glomerulonephritis, active, what we would now call class 3 or class 4, most of them died from renal failure. So the natural history of this is actually defined by the glomerular lesions, but because we treat it, it becomes defined by the tubulointerstitial scarring. There have been various classifications over the years, but in 2004 there was a reclassification of glomerulonephritis and systemic lupus, which is known as the ISN-RPS classification. And my colleague Terry Cook, who's our renal pathologist at Hammersmith, was an author, and I'm indebted to him for many of the following slides. People get very worried by lupus nephritis and classification, and Terry and others have developed this algorithm which I think and I hope makes it simple. I'm going to go through that and then show you some of the histology. And essentially, when you're looking at the biopsy, you simply say, are there active or sclerotic lesions? If there are not, you look for membranous change. If there's membranous change, it's class 5. If there's no membranous change, you look for mesangial hypercellularity. If there's that, then it's class 2. If there's no mesangial hypercellularity, then you're looking for immune deposits by immuno, and it's a class 1. In truth, you should very rarely be biopsying people who've got class 1 or class 2, because clinically they'll have very little wrong with them from a renal point of view. And in fact, we only really see it in transplant biopsies. Then if they've got active or sclerotic lesions, it's going to be a class 3 or class 4. It's a class 6 if everything's sclerotic, and you really don't want to be seeing that. If everything's globally sclerosed glomeruli, we're not talking about tubular interstitial disease here, then it's a class 6. So if they have active or sclerotic lesions, the simple division now between class 3 and class 4 is whether 50% or more of the glomeruli are involved. If there's fewer, it's class 3. If there's more, it's class 4. In class 4, if there's more than 50% of the glomeruli have segmental lesions, and I'll come back to the details of this, then it's a class 4S for segmental, and if they're not, if they're nearly all global lesions, then it's a class 4G, and that's it. That's lupus nephritis classification on the ISN-RPS. We also say whether there are active or chronic lesions in either a class 3 or class 4, and I'll come back to the detail of that. The classification was done because there was confusion from between previous versions. You had a class 1 that was normal kidney, which was an odd concept. There were fuzzy borders between the classes, and there is some evidence for different outcomes of segmental versus global disease, which I'll come back to. To do the ISN classification, you have to have light microscopy and you have to have immunohistology. There was recognition that worldwide EM, electron microscopy, is not necessarily available, but I have to say we always do it and find it hugely useful. And it's certainly very useful when you're talking about histological remission, but it's not essential for the classification. On immunohistochemistry, what you're looking for is what we call full house: IgG, A and M, C1q, C3 and C4. And the presence of C1q and C4 indicate classical pathway activation and should always make you think about lupus nephritis if you see it on the biopsy. So just to go through some histology for you, minimal class 1 or minimal mesangial lupus glomerulonephritis, essentially normal. That's a nice example of a normal glomerulus on light microscopy, but you see on immune fluorescence or immune histochemistry immune deposits of full house. So that would be a class 1. Sorry, that should say class 2, I apologise. Mesangial proliferative lupus glomerulonephritis, you have mesangial hypercellularity, and pathologists are very precise. That is defined as at least 3 mesangial cells per mesangial region in a 3 micron thick. I do it much more simply. There are too many cells there, and there clearly are. And that's mesangial hypercellularity, and you see mesangial electron-dense deposits on EM. The clinico-pathological correlation is actually these patients might have a bit of hematuria and they might have proteinuria, usually less than 1 gram in 24 hours. And the recommendation is actually that you treat according to extrarenal disease and you don't treat this in its own right. And you should rarely be diagnosing it on biopsy, as I've already mentioned. In class 3 and class 4, there are either active or sclerotic lesions which involve the capillary loops or Bowman's space, and they're associated with subendothelial deposits, as I showed you earlier. The active lesions include all of these: endocapillary hypercellularity, karyorrhexis, fibrinoid necrosis, rupture of the glomerular basement membrane, which leads to crescent, cellular or fibrocellular, subendothelial deposits on EM, and intraluminal immune aggregates or hyaline thrombi. So this will be a typical biopsy for a class 4, in fact, because all the glomeruli you can see there are abnormal. And you can see it very simply here. There are far too many cells. So the things that should strike you here is there's really no open capillary loops, perhaps 1 or 2 there. There are far too many cells here, so you've got endocapillary proliferation, and you've got these great big hyaline thrombi. On high power, you may often see apoptotic, well, we always call them karyorrhexis, but of course the work from Mark Walport and Marina Botto and others has shown that these are actually apoptotic fragments which are hanging around and stimulating the immune response, which you see in active class 3 or class 4. And fibrinoid necrosis is a very bad thing to see, and you often see it in association with segmental lesions, as here. You've got a pretty normal part of the glomerulus here, but you've got this nasty pink stuff, which is necrotic material. And what you really don't want to see is a whole selection of crescents, and this is a silver stain which shows up the GBM very nicely, and you can see there's extracapillary proliferation, and these are crescents. And they're defined again as extracapillary cell proliferation of more than 2 cell layers occupying 1/4 or more of glomerular capsular circumference. But you just see them, they're crescents, and they're there. Wire loops often can be mistaken for the membranous change because they look pink and chunky, but actually they're slightly different when you look on light microscopy. There's a sort of amorphous pink material, and they are subendothelial deposits visible by light microscopy, which on a silver stain you can show very nicely the splitting of the basement membrane with deposits here. And what you can see on this EM, again to orientate you, here's the podocyte side. It's difficult to see because there's no foot processes, they've all been effaced. That's the subepithelial side. This is the endothelial, the capillary loop, which is almost completely occluded. And these are huge subendothelial deposits doing bad things in the kidney. If you see deposits at all three sites, so if you see them subendothelially, subepithelially, and mesangial, you should always think of lupus nephritis. There's very few things that give you deposits at all three sites, and tubular reticular inclusions are driven by interferon alpha, an absolute hallmark of renal lupus, but are seen in things like HIV nephropathy as well. What you don't want to see are sclerotic lesions, because you're not going to make those better. And they include glomerular sclerosis, which can be segmental or global, fibrous adhesions, or fibrous crescents, as here. This was a juicy crescent, and it's now becoming a fibrous cellular crescent, fibrous crescent. So when we describe the lesions, we talk about how active or chronic they are. So you talk about the glomeruli. Of all the glomeruli got active lesions, have some of them got chronic lesions, so glomerular scars or glomerular sclerosis, or are all the changes chronic? And that's terribly important and not recognised in the ACR guidelines that came out last year, because you wouldn't treat a purely chronic lesion unless you thought it wasn't representative. And your pathologist should be indicating the proportion of glomeruli with active and with sclerotic lesions, and indicate the proportion of glomeruli with fibrinoid necrosis and or cellular crescents. We don't use an activity index or chronicity index. We talk about the numbers of glomeruli involved. There's this further division into segmental or global, and segmental is when it's more than 50% of the involved glomeruli have segmental lesions, and it's diffuse when more than 50% of the involved glomeruli have global lesions. And you define a segment as a lesion involving less than half of the glomerular tuft. And I'm going to come back to this towards the end because it's very important. So at least half the tuft is spared. You can see here that's a normal bit of tuft. That's a glomerular, that's loads of activity there. You can see karyorrhexis and pycnotic nuclei, whereas in this one the whole tuft is abnormal. Global and segmental. Class 5 is you see capillary granular full house immunofluorescence compared to idiopathic membranous, where you would just see C3 and IgG. Here you see full house immunofluorescence, and we often see that in isolation with no systemic features of lupus. And on a silver you see holes and spikes, which I hope project here quite nicely. And they correspond to subepithelial deposits. So here's the luminal side, this is the endothelial side, this is the epithelial side, and you can see these deposits are all on the epithelial side and associated with membranous and a lot of proteinuria. Virtually all the patients with class 5 will have proteinuria, and up to 70% will be nephrotic, but some will have hematuria, but renal insufficiency is relatively uncommon. If you see class 5 together with class 3 and class 4, we've got rid of that awful classification of 5C and 5D. It is class 3 and 4 plus class 5. And to do that, you have to have more than 50% of the tuft, or more than 50% of the tuft, and more than 50% of the glomeruli showing membranous change. So if you see the odd subepithelial deposit, it's not a class 5. But if they've all got subepithelial deposits, or they've all got membranous change on light, then they've got a 3 and 4 plus 5. And you don't want to see class 6. That's when everything's gone and you're not going to make any difference whatever treatment you do. The clinical features, one of the questions people often ask, why do you biopsy? I know what it's going to show. Well, actually you don't. And the clinical features do not distinguish. This is data from a series of ours of 50 patients who we've treated in a particular way, which I'll talk to you about in a moment. But you can see these are the patients divided up by their class of biopsy at baseline, class 3, class 4 and class 5. And this is their serum creatinine, and the class 5 have a wider spread. This is their serum albumin, and you can actually see the class 4s have lower serum albumins than the class 5s, who people often think of as more nephrotic. And similarly, the urine PCR, and we don't do 24-hour urines ever, the urine protein creatinine ratio is actually a much wider spread, and patients are more nephrotic with class 4 than class 5. So you can't always predict simply on the clinical features. Transformations on rebiopsy are relatively common. We see them often going to class 5. In the literature, they'll tell you that class 5 can go to proliferative, which it certainly can. One of the reasons why you rebiopsy on flare. There are activity and chronicity indices. They were first used by Pollock. They were popularised by Austin. They look like this. You wait for certain findings, such as fibrinoid and cellular crescents. The problem is there's a lot of inter-individual variability. They're not reported in a standard way. And actually, the ISN RPS class doesn't do that. You simply say how many have got karyorrhexis or crescents. And I have to say, on a day-to-day basis, it gives you a very good feel of how bad or not these lesions are. You also want to look for vascular lesions, an immune complex deposition causing a vasculopathy, necrotizing vasculitis you don't want to see, but thrombotic microangiopathy is important to diagnose because it's usually associated with antiphospholipid antibodies, has a very bad prognosis, and it doesn't respond to normal immunosuppression. And you can see here the vascular pole of this glomerulus is completely occluded, and that glomerulus is going to go. And here you can see arteriolar involvement with thrombosis. And these patients on the whole do very badly, and you'd certainly think about plasma exchange for a good-going TMA. The other thing you do look at, of course, although it's not part of the classification, the tubules and interstitium, you really do want to know how much tubular atrophy and interstitial fibrosis there is, and the biopsy should always give an estimate of the amount of tubular atrophy, interstitial fibrosis, and Terry will say 50%, 25%. Once you get into 50%, you're starting to get a bit worried. But you also want to know if there's active tubular interstitial nephritis, because actually those patients often do very badly and scar off, even though their glomeruli might look quite good. And you can see on immunofluorescence immune globulin deposition on their tubules. So, going back to our young man, he's been treated with MMF, didn't do anything. He's been treated with cyclophosphamide, still heavily proteinuric, remained nephrotic. So we biopsied him. What you look at, first of all, is on low power, and you can see here he's got nice there's no spaces in this biopsy. He's got nice back-to-back tubules, which is what you want to see, and in a younger person, they're more back-to-back than they would be, say, me. So he hasn't got any chronic damage, but if you look at slightly higher power, I hope by now you'll realise that all these glomeruli are horribly abnormal. There's far too many cells, there's not nice open capillary loops. If you look at higher power, he's got both wire loop changes and membranous change. Here he's got some thick-looking, rather stiff capillary loops. He's also got a lot of proliferation, and in some areas, I can't find it now, he's got rupture of the basement membrane. So he's got a nasty mixed lesion of a class 4 segmental and a class 5 lupus nephritis. And that was despite a full year of treatment. The good news was he had no chronic damage, but he still had very active disease, and he remained nephrotic. So he was the first patient I ever gave Rituximab to, a long time ago now. And in those days, we gave it as 4 doses, and we gave it with a dose of cyclophosphamide. And, of course, we blocked his renin-angiotensin system. And we gave him steroids. Things have moved on, as you'll see. And he had an excellent response. This was him in 2004. I don't know how well the dates project, but this was 1999 going up to 2006. We gave him the Rituximab here, and you can see his proteinuria peaked and came down very nicely. And his serology initially got much better. This is C4, C3, and his double-stranded DNA was sort of plateaued. But then things started to go bad serologically with a fall in his complement and a rise in his DNA, what David Eisenberg would say, be very afraid. And just at the end of this, you can see his proteinuria beginning to rise. And in fact, then age 20, he had another clinical relapse, and we re-biopsied him. So he's now on his 3rd renal biopsy. And this is reported as you would report it. So he had active lesions in 4 out of 9 glomeruli. He now has some chronicity. He had chronic changes in 1 out of 9, and he had 25% interstitial atrophy. That is not good news when you're 20 years old. And you can see here, he's now got global lesions. That whole glomerulus is abnormal. Far too many cells, no open capillary loops. He's got a tubulointerstitial nephritis, and you can see that he's lost some back-to-backness of his tubules. He's got a very active nephritis with some scarring. And that's shown, it's better on there. He's got large subendothelial deposits, he's got subepithelial deposits, he's got tubulo-reticular inclusions. You can see nicely here deposits in all sites. So he's got a class 4G, global. A and C, he's got a mixture of active and chronic lesions, and he's got a class 5 on top of that, the worst prognostic group. So we redosed him. He rapidly depleted his B cells with some improvement, but 4 to 6 weeks later, his B cells were coming back, his proteinuria was coming back, and he was more active. So we redosed him. and he had anaphylaxis. That wasn't so good. He'd almost certainly developed antibodies to the Rituximab, and then we found ourselves a little bit of a pickle. Here was a 20-year-old man. He'd had cyclophosphamide, high dose. He'd had MMF. He'd had Rituximab, and now he couldn't tolerate any more Rituximab. And in fact, all we did was increase his MMF. We measured trough levels of MMF, but we'd probably run him a little bit low, and we pushed him up to the ARMS study sort of levels, 1.5 grams BD. And he went into a complete sustained remission, and 6 years later, he's still in a complete sustained remission. He's been to university, he's working, he has had to have bilateral hip replacements. Having slipped epiphyses and then having several years of steroid is a very bad plan, and he needed bilateral hip replacements in his early 20s, but he has weaned off his steroids now, and he's well and active. We now have a slightly different standard of care, and there are trials which have informed this, and the two key trials, the Lupus trial now with 10 years follow-up, which is very important in the lifetime of our patients who are going to relapse and remit, as you've heard, over many years. And this is from Fred Husau. Low-dose cyclophosphamide is as effective and less toxic than high-dose cyclophosphamide, and it's a steroid-based regimen. The ARMS trial did not show its primary endpoint, which was supposed to be superiority of MMF over high-dose cyclophosphamide, but we've all interpreted that as showing that it was as good as cyclophosphamide. There probably is superiority in African Americans, and analysis of that trial and the Ginsler data suggested that MMF was as good as cyclophosphamide for pure class 5. It's a steroid-based regimen. So I'm going to digress because I can't resist having an audience and not talking about our study. And I apologise, but it is relevant to the biopsies, as I'll show you. So we don't like steroids, none of you like steroids, and we've heard very cogent talks at the Lupus Academy and here already about why steroids are very bad for you. And just to show you another biopsy, a typical case that we've seen in more recent years, be a 26-year-old Chinese student who presented with severe preeclampsia elsewhere. At 26 weeks pregnant, she was very hypertensive and she lost her baby. At that time, she was thrombocytopenic, but she wasn't treated. She came to us a few months later with full-blown lupus. It was severe. She had skin involvement, alopecia, hemolytic anemia, leukopenia, and she was severely nephrotic, with an albumin down to 18, a peak urine PCR of 1676, which is equivalent to about 17 grams of proteinuria. She had impaired renal function. Interestingly, her serology was negative at presentation, but there was nothing negative about her biopsy. She had a class 4G, which was entirely active, and 5. Again, bad prognosis. You can see here these huge wire loop lesions. She had a crescent in 3 out of her 13 glomeruli, but she had no chronic damage. She had large subendothelial and subepithelial deposits, and this was a bad prognostic lesion. But we had taken the view, when we merged the Hammersmith and St Mary's renal units in 2005, based on the experience in transplantation, that you can get rid of steroids. And we now have a regimen, in fact, in the Hammersmith, where patients get Campath when they're transplanted and monotherapy with tacrolimus after 1 week of steroids only. If you could do that in transplantation with better outcomes, we argued, why couldn't you do that in lupus? So since 2006, we've been using a steroid-avoiding regimen. Patients get methylpred, 2 low-dose pulses, and Rituximab, 1 gram, 2 pulses, 2 weeks apart. And they start on MMF. We titrate it up according to trough levels, and if they're not on oral steroids, we don't give them any oral steroids. We've just reported, it's in press as of this week, 50 patients with a median follow-up of 163 weeks. Our patients are relatively old. I don't know why that is. We have a renal practice. We do renal biopsies from patients all over West London. That's the age of our patients, but a reasonable range. We have a lot of elderly patients as well. Quite mostly female, the ethnicity that you would expect from West London. Quite a significant proportion do not have classical positive serology, but they've all got positive biopsies. 58% have extrarenal manifestations, and the mix of classes, and the only slightly odd thing is the high proportion of pure class 5, and I'm sure that reflects a renal practice. They were mostly treatment naive, and they do extremely well. So this is a Kaplan-Meier curve going out to over 156 weeks of follow-up. This is the curve for complete remission, and this is the numbers in complete remission at 12 weeks, 26 weeks, and 52 weeks. And just to set the scene, in the ARMS data, that figure was 8.5%, and in the LUNA trial, that figure was 26.4%. And there are more that go into persistent partial remission, but they do plateau. Notice also they continue going into complete remission beyond the first year. And of course, we do start to see relapses, but they've had very little immunosuppression and they've had no oral steroid. It doesn't matter what their class of biopsy is at baseline. So whether they're class 3, class 4, or class 5, they have the same time to remission and the same proportion going into remission. As you would expect, there's a significant fall in their proteinuria, and we know from Fred Hussal's data that we want to see that early, and we do see it early. It's significantly down by 3 months and sustained, and the serum albumin goes up. There is, as you'd expect, not a significant difference in creatinine, because most of them have creatinines within the normal range, but we did include some people with very severe dysfunction. This was an elderly lady with a creatinine of 420 and a lot of scarring who got down to a creatinine of 120. By 52 weeks, there were 24 patients who were not in complete remission. 2 of them had relapsed. One wasn't on MMF and one really couldn't take a tablet. 3, 2 of them by 12 months, 1 at 16 months, switched as they were non-responders. But of the remaining 19, 4 had a falling PCR and went on to complete remission, and we didn't re-biopsy them. But the rest were invited for repeat biopsies because we wanted to know what was going on. 2 failed to attend, and they probably failed to take a tablet either. 8 had repeat biopsies demonstrating histological remission. And I'll show you an example of that in a moment. Histological remission we define as no active lesions on light microscopy and no new deposits on EM. So no subendothelial deposits and only old intramembranous deposits on EM. And those patients all went into complete remission without any change in treatment, suggesting that a lot of patients in clinical trials who are in partial remission because of persistent proteinuria are in fact in complete remission at those time points, but you just don't see it unless you do the biopsy. Another reason for doing biopsies is you show things you're not expecting. This patient would be a failure in a trial because she had persistent proteinuria, but she had diabetic nephropathy. She didn't have active lupus nephritis. 3 had active disease and were redosed with Rituximab, and 1 had active disease and had her MMF optimized and went into remission. The most important slide, I would say, of the whole talk, regardless of biopsies, is that of our 50 patients, only 2 who stayed on the regimen have required oral steroids. 1 has required long-term oral steroids because she's got terrible pericarditis. We couldn't wean her off them. And, of course, once you're on them, it's very hard to get off. But she's now, in fact, down to 1 milligram and pregnant, and she's staying on a 1 milligram while she's pregnant. 1 patient had 3 short courses for cutaneous lupus. So I think that's pretty impressive because a lot of these patients had severe lupus nephritis. So going back to our young Chinese girl, how did she do? She had bad lupus. She had systemic and renal lupus. She had a poor prognostic lesion. She went into partial remission within weeks, and she was in complete remission by 8 months. And she wanted to re-biopsy because we wanted to swap her from MMF to azathioprine because she wanted to be pregnant, and she said she wanted to know what her kidney showed. So this was her biopsy when she'd gone into a complete remission. And what you can already see on low power is that she's got no chronic damage. She's possibly got 1 glomerular scar, but she's got this beautiful, normal-looking glomerulus compared to her crescentic global GN at baseline. And it's even more impressive on EM, where you can see she had huge deposits at baseline, and now she has completely remodeled her glomerular basement membrane, and she's just got some intramembranous deposits. And there's very similar data from Eva Gunnarsson in Sweden showing resolution after rituximab of the histological changes. So we're going to do a trial, and this is my shameless plug, which you will probably hear if you come tomorrow morning as well. But we've, using the rationale that we need to get rid of steroids in these patients. And we're going to try and show that our Rituximab protocol is not inferior. We're not aiming for superiority to MMF in steroids in efficacy and has a better safety profile. If it works, it will be a game changer because we'll be able to avoid oral steroids in the majority of patients. It's an open-label, randomised, multi-centre trial. We've got, in fact, 18 UK units who are interested. Ron van Vollenhoven is organising the European network, and Brad Rovin's going to organise the US network, and we'd very much welcome a South American involvement. We need 252 patients. In fact, it's an 87% power with a non-inferiority margin of 20%. We've assumed a very high complete response rate in the control group. The range from trials is 18 to 40%. And there will be key secondary endpoints looking for safety signals from lack of steroids. The primary endpoint's at 1 year, but we'll be following them all up for 2 years with an option of 4 years. These are the people so far involved. I'm the chief investigator. These are my colleagues at the Hammersmith and David Jane at Cambridge, some very eminent rheumatologists. We have a paediatrician, because we're going down to age 12. The Imperial Clinical Trials Unit is running it, and Terry Cook's the pathologist. We have some funding. This is an investigator-led, non-commercial trial, so there's no money for anyone in this, but we have got the Rituximab funded. If you're interested, please email me, l.lightstone@imperial.ac.uk. I will now get back to the main part of the talk after my shameless plugging. Sorry, I'm going the wrong way. The real problem is that some people do badly. We can predict some of it. We know if they've got severe disease, if they present with a high creatinine, but there are some people who just rock off. You think you're going to do well, and they don't do well. I think there has to be a genetic predisposition. We know from Barry Freeman's original work that if you have lupus nephritis and you've got end-stage renal failure, you're very likely to have relatives with all sorts of renal disease that will have gone into end-stage renal failure. We know that's probably associated with the ApoL1 gene, and I believe there's a paper being presented here this meeting about that. And of course, the number 1, 2, and 3 causes of doing badly are not taking your tablets. But there are some patients who you just feel the odds are against them. This is a young African Caribbean boy who presented to us with a class 4 GA, so no chronic damage. He did have a lot of crescents. His creatinine was abnormal, but he had a partial remission. At 8 months, his creatinine was rising again. Now he had segmental lesions, A and C, so he's getting some chronic damage. He had 2 out of his 20 glomeruli are obsolete, 3 had necrosis, he had segmental scars, and he was getting tubulointerstitial scarring. And by 1 year, he had a rising creatinine, he had a class 5, and he had tubulointerstitial nephritis, and all the changes were chronic in the class 4. And looking at that in higher power and relating it to how we treated, he did have very, very active lesions at the outset, and I think we were bold and probably foolish to give him the Rituximab regimen. But he was a young African Caribbean. You're supposed to do better with MMF. He always took his tablets. In retrospect, he didn't fully B-cell replete. He then went on and had nasty segmental lesions. We gave him methylpred and Rituximab and the Lupus regimen. He didn't respond. At this point, we were actually thinking about giving him Eculizumab, the anti-C5a antibody, but there was no active complement deposition or active proliferation to treat. And in fact, we did what you do in desperation, which was plasma exchange and IVIG, but needless to say, it didn't do anything. And he's ended up in renal failure. So who's going to do badly? I've already said those with very severe disease, children do badly, those with recurrent flares. The poor prognostic lesions on biopsy are large numbers of crescents or fibrinoid and severe segmental lesions. And the question is, can the biopsy predict? I've already said that the activity indices, or the activity score, if you like, when you say how many have got crescents and how many have got fibrinoid, are a guide, but the absolute indices do not tell you. But there is a whole debate out there about segmental versus global class 4. And you talk about segmental lesions when it's less than 50% of the tuft, and more than 50% of the glomeruli have segmental lesions. Going back to previous classifications, there was the class 3 in the previous classification actually talked essentially about segmental lesions as class 3 and global lesions as class 4. And there was a paper that suggested those patients do less well. You can see over time the percentage renal survival, and the class 3 were doing badly. And Gary Hill's done some very elegant work from Paris looking at repeat biopsies, but also segmental lesions, and suggesting that there are major differences between predominantly segmental proliferation and predominantly global proliferation. And you can see here, particularly if you've got segmental lesions, diffuse segmental and diffuse global lesions, you do, this is labelled the wrong way round, you do much less well if you've got segmental lesions. And he's looked quite carefully at this from a histological point of view and says that global proliferative lupus nephritis behaves as what we classically think of as an immune complex nephritis. Heavy deposits, particularly subendothelial, proliferations marked, often all the glomeruli involved, macrophages and monocytes are prominent, and there's a negative correlation. These are the patients who are hypocomplementemic, have high antibody levels. When you've got segmental proliferative lesions, they're often relatively poorly immune. There's often prominent fibrinoid necrosis, and they look much more like vasculitic lesions, though they're not necessarily associated with an anchor. And he's postulated there's a different pathogenesis. And then Mel Schwartz has taken this further and argued that what we're missing in the current classification are severe segmental lesions. And this just does get a little nerdy and pathological, but actually it's quite interesting. Because the definition is based on a segmental lesion being less than 50% of the tuft, Mel Schwartz has argued that actually there are some segments which are bigger than 50% and more severe, but they're not global. And if you call those 4Q, and you look at the outcome, there is no difference in outcome between classical 4S and 4G. But if you look at those with large, nasty segmental lesions, like our young man had on his second biopsy in that panel of 3, they do very badly, suggesting there's a different mechanism that might require a different treatment. So there is a discussion at the moment about whether some modification of the ISN-RPS classification is necessary, and we may be failing to identify a group with worse prognosis and different pathogenesis. What Gary Hill has also done is highlighted the predictive power of the second renal biopsy. He looked at 71 patients, 55 class 4, 9 class 3, and 7 with a mix of 4 and 5. Most of them had cyclophosphamide and steroids, but 13 had steroids alone, and he did a protocol biopsy at 6 months. 18 patients eventually doubled their serum creatinine, which he calls creatinine times 2. And the predictive factors, on the initial biopsy, there was very little that was predictive, certainly not the activity index, certainly not the chronicity index, possibly tubulo-interstitial inflammation. But persistent inflammation on the 6-month biopsy was predictive. And the best predictors were glomerular and tubular macrophages on the second biopsy and persistent mesangial proliferation, glomerulonephritis. So the sort of not segmental, you see it, a mesangial proliferative pattern on biopsy is associated with a worse outcome. Again, highlighting the importance of repeat biopsies. So we do repeat biopsies to look at transition of class, which might alter your treatment. I would argue you should be doing them for looking for histological remission, prognostically to tell you about the numbers of macrophages, which will predict a poor outcome, and the degree of tubulo-interstitial damage, which will grossly influence treatment choice. We're not yet at biomarkers that will replace the renal biopsy, the repeat renal biopsy. Nothing replaces the first renal biopsy. In the long term, there are many groups, ourselves included, who would like to think that we can do a urinary MCP1 or a urinary tweak or a mix of them and tell you how these patients are going to do and what's going on in their glomeruli, but we can't do that yet. So in summary, the renal biopsy is the only way to diagnose and monitor lupus nephritis, and don't hesitate to rebiopsy. Biopsy early. Sometimes you'll be surprised. And I put that there to remind myself. I'll give you a very brief vignette of a patient who presented in pregnancy. It's a bit of a sad story. A Somalian lady who presented to a colleague in a district general hospital at 12 weeks pregnant with Rho, LAR, DNA high, low complement, alopecia, joint pains, proteinuria and hypertension, lupus. He wanted her to have a biopsy. She was still very early in pregnancy. She ran away. She reappeared at 22 weeks. The baby had complete heart block by that point, presumably related to her Rho, and subsequently died in utero. She didn't want a termination, and the baby didn't grow and died. She was delivered. She continued to have proteinuria. We all assumed this was lupus nephritis, but we thought we ought to biopsy her because I've been immunosuppressing her blindly through pregnancy, and I thought we ought to know what we're dealing with. And in fact, she had focal segmental glomerular sclerosis. She does not have lupus nephritis at all. And we see in our Somalian population and our African population FSGS. So she had a completely different disease in her kidneys than she had systemically, and it completely changed how we immunosuppressed her. So you don't always get what you expect on biopsy. We would biopsy on relapse, we would biopsy on failure to remit, and I would argue that there's an indication to do protocol biopsies. The controversies about segmental and global remain. All it remains for me to do is to thank my colleagues who contributed to the data, particularly Marie Condon, who brought together Rituximab data. These are my colleagues, particularly Tom Cairns, who runs the Lupus Centre, and Terry and Candice, who are our exceptional renal pathologists. Thank you very much.
Thank you, Liz, for your excellent, thank you so much for your excellent conference. Now, question session is open. Please use the microphone and identify yourself.
Please, may I go ahead with the first question? Could you please comment on how risky is the renal biopsy procedure? How frequently are there bleeding or other accidents, and in which situations there should not be performed a renal biopsy?
Okay, so there are certain basics. You don't want them anticoagulated, you don't want them thrombocytopenic, and you want their blood pressure controlled, and there's a must. So actually some of these patients present really acutely, horribly nephritic, very edematous, and you wait, and you'd be treating on best guess until that point. Then the risk's entirely dependent on your operators. My colleague Tom Cairns does 400 to 500 native biopsies a year. He would quote a 1 in 1,000 risk of needing a blood transfusion and an infinitesimal risk of needing embolization for bleeding. So very low risk in very experienced hands. He does his own ultrasound. Is superb at it, and I've got 2 or 3 colleagues who do them. I don't do them anymore. So I think it does depend on the experience of the operator, and we're a large centre doing huge numbers of biopsies every year. So I think that makes a big difference. If you're a rare biopsier, then it becomes a more dangerous procedure, like all invasive procedures. David de Cruz has this interesting observation in patients with severe antiphospholipid syndrome that they do bleed. Now, that hasn't been particularly our experience, but we don't have that same group of patients, and apparently they are higher risk for bleeding. So those you might be more circumspect about doing it in. But in our hands, really, our main problem actually is when you get what looks like a scar kidney, but you've got someone with a creatinine of 120, and presumably you've just gone into the same point twice, which seems unlikely, but we're assuming we're hitting a cortical scar for some reason. But actually, complication rates are remarkably low in our hands, or my colleagues' hands.
Next.
Thank you. What is your interpretation of the discrepancy found in the results found in the maintain study versus the ALMS data?
Do you mean the maintenance therapy trials? Okay. Right. Well, Fred's in the audience, so I think he's probably more able to answer. They were different trials. It's like comparing apples and pears. The ALMS study had 370 patients. They only took the responders, whether they responded to MMF or cyclophosphamide. They had different cyclophosphamide to Lupus, and they only took the responders and then looked at them with the MMF. They had markedly different ethnicity compared to the Lupus group. And in that trial, MMF was definitely superior. In the maintain trial, they were randomized from the outset. They all got Lupus, and then they either got azathioprine or MMF, and there was absolutely no difference. I take it and it was a much smaller trial. I take it in a positive light because we do have to change patients from MMF to AZA because they want to get pregnant. And actually, I'm reasonably comfortable with that. I think particularly patients of non-white ethnicity probably do better with MMF long term. But the Lupus data are the Lupus data, and they are very good data. So I think if you've got a Caucasian patient, it's very reasonable to use either, depending on preference. I think a non-white patient, I would probably always go for MMF in the first instance, but I would have few qualms about changing to AZA when they want to get pregnant. But they're very different trials.
I haven't seen, by the way, the word azathioprine in any of your slides.
We do use it. We don't use it for induction.
Any particular...
No, we swap patients to MMF to azathioprine when they want to get pregnant. We do use it in pregnancy, but I'm afraid we use an awful lot of MMF.
Next.
Thank you. Silverman from Toronto. Very good talk. I have a couple quick questions. You say you shouldn't see mesangial. I would actually say you should see mesangial because, as you know, there are low-grade proteinuria who have proliferative, and if you wait for high-grade proteinuria, one may easily have damage. So I have no problem with mesangial lupus on a biopsy because...
But what do you do with them?
I ruled out proliferative. That's why I do the biopsy, because I can give you equal number of patients who have 500 milligrams of protein and some will have proliferative. So that, I agree with you, I don't treat them. but I do it for exactly the reason
I think
you
if there's
say.
a change, I think you're right. What you shouldn't do is sit on persistent proteinuria. That's the message I always give out, and assume that there's nothing going on. So I think if it's changing and it's rising, it's reasonable to do. We do have a problem when we diagnose it too early because we don't want to treat then, and then when do we re-biopsy? And these we follow these patients. If they've got rising proteinuria, we tend to follow them very hawkishly. We tend to capture them early. I agree with you. Once they're under follow-up, you're probably more likely to pick up class 2, but we don't often, I have to say.
But that may be because your practice, if you're a rheumatologist, you tend to treat extrarenal, which may mask.
Yeah, we do treat extrarenal. Believe me, I treat extrarenal disease. And I run a joint clinic with my rheumatologist.
I know. I was teasing. One final question. You made a point that I think is a good point, of MMF trough levels. And I think your first case was a great case of when we assume one dose fits all of MMF.
Oh, that really doesn't. I mean, we dose to trough levels. If you can criticise us, it's because we often underdose, I think, because we get to a trough and we're happy, and actually you can push it. But we have patients who are absolutely perfect on 250 BD, saves you a lot of money, and who I would probably kill if I'd given 3 grams of. So I do think it finesses it, but I think you should push it up, particularly if you've got persistent proteinuria.
On the same, you ever do short PKs?
Sorry?
Short term, like a 6-hour PK?
Yeah, well, we're just getting into that. I've got a colleague who's just visiting from India who I believe has published on 6-hour PKs. We've always done 12-hour, but we've moved our clinic to an afternoon clinic, so that's becoming impossible. So we're just gathering our own data on short PKs. Do you use them?
Yeah, I find it better than trough.
I need to talk to you afterwards.
Yeah.
Hello, Alvarellos from Sweden. Would you like to specify how you define clinical and how you define histopathological response, and what you mean when you say complete remission?
Yes, so complete remission from our point of view is proteinuria. We'll use a PCR, the units are different across the pond, a PCR of 50, equivalent to less than half a gram of proteinuria a day. And I think, particularly in light of David Wolf's recent publication, that's a pragmatic decision. The true complete remission will be less than 0.2, but it takes years to get to less than 0.2. We say less than 0.5 grams proteinuria, and normal renal function, if it was normal or baseline, or within 20%. You know, our lady who had 40% tubular interstitial scarring was never going to get to a normal creatinine. And then a partial response is nephrotic to non-nephrotic, and if they were non-nephrotic, a more than 50% reduction. And it's nearly always defined by the proteinuria rather than creatinine. And we don't do urine sediment. Don't do urine sediment.
More questions? No? Okay. I would like to thank Liz again for this great presentation and the audience for the participation.